Okay. So unfortunately, Dr. Roman could not be here. She had a last-minute travel. I think she's in South Africa. And many of us do know who she is because most of our children do have cortical vision impairment, and she is the godmother of CVI. She wrote the book that I personally gave to Josie's vision therapist, and it really made a huge difference for Josie. So, so we did get her to answer your questions. So when she said she couldn't be here, I sent her parents questions, and she did put together a video for us answering those questions. So we will play that now, and unfortunately we won't have a Q&A, but send me any questions you have and we will get them to her.
Hello, my name is Christine Roman, and I'd like to thank you for inviting me to participate in the FOXG1 conference. I'm so sorry I can't be there with you in person, and though this very brief presentation on CVI is virtual and we are not in the same room, I hope you know how important your work is to not only your own community, but the greater community as well. So thank you for what you do. I had a few guiding questions that I'm going to refer to in this little short presentation. The first one is presented as, what is CVI and why does this happen? Well, CVI is a brain-based form of visual impairment, and it occurs when there is injury to the visual pathways or processing centers of the posterior part of the visual system in the brain. It can be from, actual damage to the structures, but it can also be because of injury or impairment to the function of those areas. This is probably the reason that children with FOXG1 so frequently are diagnosed with CVI. In fact, it has been my experience that more and more rare genetic conditions are associated with CVI, though frequently children remain undiagnosed. So please be on the lookout for children who have new diagnoses of any rare genetic type for the potential of impaired function of their visual system in their brain. So CVI is an interesting form of visual impairment because often the eyes can be perfectly normal, but what happens beyond the eyes is where the injury or the difference in function occurs. Children with CVI often can see the world and their eye exam may be fairly normal, maybe perfectly normal, but they can't always interpret what they see. So as vision educators or any person who's dedicated to helping children with CVI know, we have to do a couple things. We have to help support a child with CVI by creating access, by reducing the complexity of their environment, adding light, adding movement, using light and color in a certain way so that the child can actually perceive where the target is. But then we have to go further and we have to also create methods for interpretation of what is seen. And this happens through language. This happens through the teaching of salient visual features. It's important to recognize that CVI is diagnosed through three basic criteria. One is an eye exam that doesn't explain the way the child uses their vision functionally. The second criteria is a history of a neurologic condition or injury, which could be congenital or acquired. So in FOXG1, that would be the congenital form. And the presence of 10 visual and behavioral characteristics associated with CVI. These characteristics include the need for color, attention to movement, that's actually quite an unusual degree of attention to movement, the presence of visual latency, visual field differences, especially lower visual field difficulties, difficulties with visual complexity, the need for additional light in certain ways, backlighting or task lighting. It can also include difficulties with distance viewing, difficulties with novelty. So children with CVI often sort of gravitate toward the same activities over and over, same videos, same interest. And then difficulties with the visual motor match. So they often use a distinct pattern of look and reach, where the child looks toward a target, glances away, and then reaches kind of without looking. When those three elements are present, the child is generally showing a profile of a child with CVI. So why is it so prevalent? And the next question was, I'm looking at the questions on the other screen. Why is it so prevalent in CNS disorders such as FOXG1? Well, again, I think it speaks to some genetic miscoding that changes the function, not the structure necessarily, but the function of how vision is processed in the brain. So I think we cannot say with certainty all of the subtleties, especially across various, rare genetic conditions. But we know that we have a way to actually identify CVI, and that's the key. That's the key, is to look for an eye exam that doesn't explain how the child's using their vision, the presence of a neurologic condition, including a chromosomal difference, and the presence of the characteristics. Another question is what parents should look for to determine if their child has CVI. So it's my experience that parents definitely know. My work is really founded on what I've learned from parents. And the parent interview that is part of the CVI range assessment is testimony to that. Parents will know, but they might not know what it's called, and they might not know it's actually visual impairment. And in some cases, their child might be misdiagnosed as having something else, like autism, for example, if the clinician or the diagnostician doesn't know CVI well. Parents should look for things like a child who can't really recognize their face in all contexts. The child might rely more on your voice than your face to know who you are. The child with CVI often likes things that move or things that are shiny, might stare at light, shows interest in possibly in YouTube videos, but not TV, because the TV can't account for latency, for example. That they'll see a delay in the way their child responds to something, and that they seem to bring things close to their face, and so forth. So a lack of interest in books is another very simple sign that can really suggest the possibility of CVI. The next question is what parents should do about it. Well, that's really, I think, critical. And many parents have found ways to have their child be evaluated properly. We use the CVI range, obviously, at Pediatric View. And I believe strongly that a functional vision assessment designed for children with CVI is a critical way to find out what the child's current level of visual function is. The actual formal diagnosis of CVI is generally made by an ophthalmologist, neuro-ophthalmologist, neurologist, sometimes a geneticist. It's usually made by an MD. But even if that diagnosis is not given in a timely fashion, educators should be astute to the signs of CVI and provide supports immediately. We don't have to have a formal diagnosis of CVI to know a child is struggling visually. So it's critical that parents find someone who can conduct, in my opinion, the CVI range to get a sense of the level of CVI. Not all children present the same way, so we need to figure out kind of on a 0 to 10 continuum where this child's level of CVI exists. Once we have that number and we have a sense of how all the characteristics look in this particular child, then we provide intervention supports at that level. And the expectation of improving vision is a reality. If we provide the correct supports and the child's able to use their vision in meaningful activities, things that matter to them across the day, it's very likely that the child will show improved vision, which we can continue to measure using the CVI range. So the last question in the list was the best ways to improve a child's level of CVI. How do we help them improve their functional vision? And it really occurs in ways in an organized fashion to provide access and interpretation of what is seen. So, for example, if a child's working on a fine motor activity or they're learning to mark with a crayon, we might adapt that by putting translucent paper on a light box, using a fluorescent marker, and making sure it was quiet in the environment. Those supports are going to encourage the use of functional vision, which is going to change how the brain is reacting and hopefully build more and more vision. If adaptations and accommodations occur meaningfully across the day, the likelihood of improved vision, in my experience, is quite high. So there were a few other questions that I was asked to address, and I'm going to take a look at those for a moment now too. One question was, how can we know our kids have CVI when we can't communicate with them? Well, if you know someone who can conduct the CVI range, the ability for the child to speak to us is not necessary. If they have AAC, it's great, but very often parents will be able to interpret a child's sort of response. They like that, they don't like that. But mostly, if you know how to conduct the CVI range, you know what those behaviors look like and how you can perform various activities within the assessment to get at the heart and soul of CVI. It is not necessary that a child tell us. They don't have to read an eye chart. They don't have to tell us what they see. Those children who can tell us have taught us a lot, but it's not necessary. So you'll see things like the child will stare at light. The child will like things that move. The child won't necessarily recognize your face until you talk. Those are things that are examples of things that are free from actually being able to be reported by the child themselves. Another question is about strabismus. Lots and lots of individuals with CVI have strabismus, and so is that surgery useful in helping to improve the functional vision of a child with CVI? And it might be. This is a decision that's between the family and that eye doctor. But the eye turn itself, when corrected, is generally a cosmetic repair. And I think, again, that's a very important question to really review with your eye doctor. Strabismus surgery is not a treatment for CVI. Another question is, a child from birth puts one eye in, and we've been told she has learned to see only with the other eye, and that it's a serious surgery for aesthetics, but wouldn't be able to see better. That really relates to the previous question. So why does that eye turn in? One eye turns in or out because both eyes are not seeing a target exactly the same way, and therefore creating double or blurry vision, and the brain doesn't like that. So the brain will get one eye out of the way, usually the less dominant eye, in favor of clear vision with the eye that's aligned with the target. It's strabismus surgery, from my understanding, and it is not a long or highly intrusive surgery. So again, if that's something that you think would be useful for your child and something you discuss with your eye doctor and you feel you want to go forward, that's not part of my professional parameter. At our vision assessment this week, our TVI, she feels that the child is seeing more with his peripheral vision than straight on. What are some ways to broaden his visual field? So we don't really work to broaden a visual field by therapeutic approaches. Rather, we give this child many experiences with vision, including the use of learning to identify targets in their environment. And if that conductivity, if the connections for vision occur strongly enough, consistently enough, we have an expectation that all of those characteristics, those 10 characteristics, will improve. So it's not that we get in there and we try to manipulate one characteristic and say, let's try to open up your field this way. Rather, we try to help the child very naturally say, if your child's always used to finding their spoon on the left, then maybe put it on the right for a while and say, that spoon could be somewhere else right now. Have a look. We provide opportunities. If the brain can do it, it will, but it's not something that kind of repetitive therapeutic practice would actually help. Be careful again about the lower field issue, because it tends to not change, and lower visual fields are very, very challenging for individuals with CVI, children who move independently in one way or another, often use a cane to detect a drop-off or a step or a surface change. Another question about best eye gaze communication programs. I work closely with the AAC community, and I know they don't appreciate that question because my heroes in AAC say you shouldn't ask what device, you should ask what does the child need. So sorry about that little moment, but really what we want to make sure is that if there is a visual display, that there is plenty of space between the symbols, that the symbols can be interpreted, so they're photographic images whenever possible. Sometimes we use a color bubbled word instead of a cartoon-like symbol to represent something. So there are ways to talk with the AAC community. There are resources. The Bridge School has a great website that will introduce you to some ideas about how to consider the proper approaches to AAC for children who require that. And then, do our children really need glasses? It's hard to get to wear them. So if a child has an acuity issue, and glasses would help, with that refractive error, nearsightedness, farsightedness. Of course, we want to encourage them to wear glasses, but many children with CVI don't tolerate their glasses, especially if they're for farsightedness. My suggestion is follow your child's lead, continue to have this conversation with the eye doctor, and know that many eye doctors have shared with me that they're not 100% sure they're getting exactly the refraction a child needs, even though the equipment is refracting properly. The way the child's interpreting what they're seeing could make it more or less comfortable for them to wear their glasses. So I thank you for those questions. I hope my answers were somewhat helpful. I just want to conclude by saying this topic is a very, very important one, and a child's visual impairment, in this case we're talking about CVI, impacts every area of their development. And so please do your best to find, a vision educator or someone in your child's world who has depth and breadth of knowledge of CVI. And if we can be of any help to you at Pediatric View, at the Children's Home and Lemieux Family Center, please don't hesitate to contact us. Thank you for your time. Enjoy your conference.